Great. Well, welcome again. Thank you. Tonight, we are going to do a Fertility 101 presentation. As the presentation goes on, please put any questions you have in the chat. We have a few members of the Kindbody team who are here to answer specific questions, but we'll also gather them at the end and share them back with our doctor. So if you have specific questions for them or for Roberto, our special guest tonight, please put them in there and we'll share it. We'll go through those at the end. No question is a silly question. And if you have any questions that you're slightly embarrassed or anything to ask publicly, feel free to just DM it to me and I will share it privately, or I'll share it with the group, but I won't anonymously for you. So let me get the screen started, the presentation going, and we'll get started. Share and send. Welcome. So thank you all to Kindbody's Fertility 101. We're so happy you're here. Tonight, we are joined by Dr. Kristin Bendikson, who is one of our Kindbody REIs. She is in LA. So if you're there, look her up. Same with Dr. Melinda Henne. She is in our Los Altos, San Francisco Bay Area clinic. And Roberto Fontanez, who's one of our laboratory scientists who does all the magic after the doctors do all their magic and helps build our families. We're so happy everyone's here. And Dr. Bendikson, I'll let you take it from here.
Thanks, Amanda Lynn. I very much appreciate that warm greeting. And thank you so much for everyone for being here tonight. So one of the reasons that I joined Kindbody in the very beginning was that my passions were so aligned with this company's, and we are truly on a mission to make reproductive health care and fertility care more accessible for all. And the term "for all" for me is so important this month, with it being June and being Pride Month, because I think that making accessible reproductive care for all means that's regardless of your gender, identity, sexual orientation. We want to make that care inclusive for you. So how do we actually improve access to care for all individuals who are interested? And we do that by actually providing a full complement of services. So yes, we do a lot of fertility here at Kindbody, and we actually do and provide the full complement of fertility services. So that starts out with very simple things like fertility assessments. So if you don't know anything about reproduction and you're just interested in building your family, we can help you with that. We can do virtual consultations. In the clinic consultations, we have the full array of fertility services, starting with egg freezing and embryo freezing. We do IVF. We do simple treatments like inseminations, and we can handle really complicated and more intricate treatments like donor egg, donor sperm, and using a gestational surrogate. But at the same time, besides just fertility treatments, we also provide gynecology care. So we can do well women checkups, urgent care, GYN visits. We can handle any type of contraception, IUDs, and even simple pap smears. And there's lots of reproductive issues that can impact fertility, like polycystic ovarian syndrome or PCOS, endometriosis, fibroids. All of those things may have an impact on fertility, but they can actually also have an impact on a woman's life outside of her fertility. And so our healthcare providers can actually help with any of those issues. One of the wonderful and unique things about Kindbody is that we actually provide a true 360 view of reproductive care. And so that includes all types of services, including LGBTQ services, dealing with egg donor, sperm donor, gestational surrogacy, and looking at the whole process from a very well-rounded position that includes thinking about it from the wellness perspective, nutrition, counseling, acupuncture, and we can't forget mental health, because that's so important when we're thinking about fertility treatments. And so by providing that 360 care, we can serve more people. One of the important things at Kindbody is that we truly believe that fertility and reproductive care is essential. And one of the main pillars of that belief is education. Knowledge is power, and reproductive knowledge therefore must be a priority. And that is especially important for women because women have age-related fertility issues. And so time can sometimes be of the essence, and time can sometimes be an important factor in the to take into consideration when one is thinking about their reproductive plans. The other important component of really making reproductive care essential is not just providing more access to more people, which we truly believe in here at Kindbody, but it's also making sure that that care that we provide is welcoming and inclusive for all individuals and couples that are seeking it. So part of the knowledge and teaching that we have to think about is that gap of knowledge where we're not really taught that much about building our families. I think all of us can harken back to elementary school, and maybe we cringe when we think about those puberty talks that we had to go through in 4th and 5th grade. And then kind of again in high school, thinking about all of those talks about preventing pregnancy. And God, those were so embarrassing, right? But it's so easy to reach so many people because kids are in school, right? But we're in so many different places in our 20s and 30s. And so there is not one place where we can reach young individuals and couples so that we can help them think about how they can best plan and build their families in the future. And so that path of building a family, sometimes that can be really easy and straightforward. And other times it's more complicated. And when it's more complicated, that may involve treatments. It may involve IVF. It may involve using an egg donor, a sperm donor, having to use a surrogate. And so it's really important that you understand, one, what are the potential paths that you may have to go down in order to build your family. So for women, all right, a lot of that path actually just kind of starts from the very beginning and really understanding what are those time limitations and age limitations on having a baby. So it kind of starts all the way back at the beginning, and that's because women are born with all the eggs that they're ever going to have, and that's around 2 million. And by the time a woman gets through puberty, well, she's not a woman at that point, clearly, right? So, but when she goes through puberty, she's only going to have 300 to 400,000 eggs. And so that means that she's losing a ton of eggs from birth just to puberty. And then from puberty to menopause, those 300 to 400,000 eggs, they completely go away. All right. And so what that means is that a woman is losing many eggs, maybe up to 1,000 a month at any given time. And that happens whether you're on birth control or any kind of hormonal contraception, whether you're bleeding regularly or not, that process happens. And yes, it's a little bit unfair, right? But you know what? We can't necessarily change biology, but we can utilize our understanding about biology to better plan, all right, so that women can really achieve the family that they truly desire in the future. So in terms of actual aging, right, I think so many people talk about that age of 35, like some magic number where all of a sudden, you know, I hate the term. People say geriatric pregnancy. I'm sorry, I'm way past 35 and I don't feel geriatric yet. But geriatric pregnancy is such a horrible term. You can have a baby at 35, you can have a baby at 40, and you can have a very healthy pregnancy. The problem is that the age at 35, this is where things start changing a little bit and changing more significantly. And it's not actually a cliff where your fertility falls off. And in fact, actually, there's a fair number of women that have lower numbers of ovarian reserve before the age of 30. And we feel like that number may be as high as 1 in 10. So you have to understand that it is kind of a slow continuum, but unfortunately for women, as we get older, both the number of eggs that we have goes down and the quality, and both of those things are really important. So in terms of the actual quality of eggs, all right, quality is really important because that's what determines your ability to get pregnant in any given cycle when you're trying on your own. It also can influence your chance of getting pregnant after going through one cycle of egg freezing or embryo freezing, because egg quality truly determines if the embryo, and when we transfer it back in, or if you're trying to get pregnant on your own, are you going to be able to get pregnant or not? What's your chance of having a miscarriage? And what's the chance that you could pass on a genetic abnormality? And unfortunately, the chance that you're going to get pregnant goes down as you get older, and the chance of miscarriages or genetic problem actually go up as you get older. I know that's not something that we always want to hear, but it's good information to have because you can make choices that can use that information to your advantage so that you really can have the family that you want. In reality, you're really never too young or too old to hear this information. It's all about really understanding where you are at this moment, where things might be in 5 to 10 years, and being proactive about that. So let's talk a little bit about just very basic ways of kind of improving your odds of getting pregnant. Well, one of the first ways is just to understand, like, when is it easiest to get pregnant in 1 month? So when are we most fertile? So if you think about a month and when it's someone's time to get pregnant, all right, we think about a calendar, all right? And in that calendar, we think about if you have a 28-day cycle, all right, you're most likely to get pregnant right in the middle of that cycle. So there's about 5 days where you're more likely to conceive. And so if you have a 28-day cycle, that tends to be around day 10 to 14. The issue is that if you have shorter cycles, that window is going to be moved up a little bit. If you have longer cycles, meaning your cycles are 35 days, that window is going to be moved out a little bit. And in fact, if you have irregular cycles, you might not be ovulating or releasing an egg at all. So it's really important to talk to a healthcare provider so that you can best understand for you and for your cycles when is the easiest time to get pregnant. But there's other things that you should take into consideration when you're thinking about getting pregnant, all right? And that is actually just thinking about your whole body. So everything that we do, everything that we ingest, all right, everything that we do in terms of exercising, that can all influence our reproductive health. So it's important, all right, that we consider what our diet is. There's no perfect diet, all right, but you want to have a healthy diet. You want to keep your body fit and healthy by exercising. All right. And then there are a lot of lifestyle factors that can have a negative impact, all right, on your actually reproductive function. So those are things like smoking, high levels of alcohol, really high levels of caffeine. So those are the things that you want to take into consideration when you're thinking about getting pregnant. You also need to think about your family history and your medical issues. You might have medical issues that might need to be addressed with a doctor before you get pregnant. And lastly, your mental health is incredibly important, all right? We wanna make sure that you are emotionally and physically ready, all right, to have your baby. Now, one of the important things that I always think is really a great message to get out is I have a lot of young women that are always asking me about birth control pills, and they often think that when they're on birth control pills, that can affect their ability to get pregnant in the future. And the answer is actually no, that it doesn't. So when a couple starts to try to get pregnant, all right, how long should they wait before they actually speak with a provider if it's not working? And the answer is, in my mind, is you should go whenever you want. I actually think that it's a really great idea that you go before you even start trying, because then you can just think about and talk to a provider about all the things that you can do to optimize your chances of getting pregnant. But if you're truly not getting pregnant, right, the definition of infertility is 1 year of trying without getting pregnant or staying pregnant. Now that's going to happen in 1 in 8 couples. That's so high, right? And in fact, actually a third of the time, there's also going to be a male factor component to that. When you're 35 or older, we actually don't want you to wait 1 year. We want you to wait 6 months. All right, because at 6 months, because you're older, that's when we're going to initiate both a workup and treatment. Versus if you're 30, all right, you're certainly welcome to come in and we can do a lot of testing just to make sure everything is okay, but we don't necessarily have to initiate treatment until you're at 1 year of trying. So at the end of the day, I think that you have to understand there's just no magic formula to get a person pregnant, and that how that's going to happen is going to be different for every single person. And you really just need to understand, like, what you want, all right, and where you stand now with your own body. And how do you do that? Well, you can do that very simply with a fertility assessment, which we offer here at Kindbody, right? And with a fertility assessment, you can have a one-on-one consultation with a fertility specialist, and that can be virtual, it can be in the office. And you can have those conversations just like we've been talking about. And those conversations are so incredibly important in terms of just planning out what you want and how you're going to go about achieving that. And at that visit, if you're a woman, what we can do is we can do what we call transvaginal ultrasound, and we can actually count eggs. Eggs are microscopic. You can't actually see them on an ultrasound machine, but every egg is surrounded by a fluid-filled sac called a follicle, and we can see those follicles. And so we can get a sense of how many that your body is kind of recruiting each month. And that lets us know how many eggs kind of in total are still left in the ovaries. We can also do hormonal tests. It allows us to understand how well the ovaries are functioning. And if you're a male, you can come in and we can do a semen analysis. And with that semen analysis, we can check several different parameters that affect a sperm's ability to fertilize an egg, like the concentration, which is the number of sperm, how well they're moving, and the shape of the sperm. So at the end of the day, truly, the path to parenthood is going to be different. And it's going to be different for individuals, it's going to be different for couples, and depending on so many different factors. And sometimes that path is straight, and sometimes it zigzags to the left and the right, and sometimes it's up and down, and sometimes that path is so convoluted and it seems like you can't see the end because it's so far away. I think the important thing is to know that here at Kindbody, we not only have healthcare providers, but we have a whole team that is here to support you, and we're going to walk on that path with you. And so now I'm going to hand this over to Dr. Henne, and she's going to talk about all the different paths that we can get you to parenthood.
Hi, everybody. It's so nice to see you here. I really appreciate you logging in. Thank you, Kristin. That was a really great overview for just general fertility information. And we're going to talk about a little bit more specifics now of things that we can do in the fertility clinic. I personally love the image of a roller coaster when people are coming to see us. I will say most people, if you're coming into our clinic, you never planned, you didn't dream as a child that you were going to be going to see the fertility doctor to get pregnant. And then the roller coaster, the path, it's twisty, it's turny, there's ups, there's downs, there's times where you go slow, 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 and it feels like it's taking forever. And then zoom, you're off at 120 miles an hour, and you might go upside down and twist around a few times before you get back to the gate. So this is kind of one of my favorite images for the whole fertility process, and we appreciate everyone who goes along for the ride. So when thinking about options for fertility, sometimes one of the first things to think about is when you want to get pregnant. How many children do you want to have? When do you want to have them? And you know, timing is tough. People have careers, they haven't found the person they want to grow a family with, or decided when they want, you know, timing is hard. And so we do have the options of doing some fertility preserving types of procedures like egg freezing and embryo freezing. And when someone's actually ready to conceive and carry a pregnancy, we can consider doing fertility treatments, things like IUI, which stands for intrauterine insemination. What that means is we're actually putting sperm into the uterus near the opening of the fallopian tubes to help with the sperm finding their way. I always joke with my clinics. I tell them sometimes, you know, it only takes one to ask for directions, but sometimes the Y chromosome has a hard time asking for directions. So the IUI is to help with that, asking for instructions. The other option is doing IVF, that's in vitro fertilization. With IVF, we're actually taking eggs from the woman, we're fertilizing them in the laboratory, and then embryos are transferred back into the uterus. And so we've really bypassed the fallopian tubes altogether. And then if sometimes we have to get more complicated, particularly for people who might have a diminished ovarian reserve, or also for our same-sex couples, or people who are electing to be single parents by choice. We can use egg donors. So these are women who have donated their eggs for another family to use. Sperm donors, men who have donated sperm for fertilization of an egg for someone to grow a family. And then gestational carriers are women who are very gracious in allowing an embryo to be implanted into their uterus, and they carry a pregnancy for someone who wants to grow their family. And those are all options for fertility treatments, and they're all things that we provide here at Kindbody. So people say, what is egg freezing? Egg freezing is kind of like a pause button. So if timing isn't right, you know, people think they want to get pregnant someday, but maybe just not right now. Or some people are like, well, you know, everyone tells me I'm going to want to be pregnant. I don't know when I might want to have children, or if I do. But egg freezing gives you that opportunity to save some eggs to potentially be able to conceive at a later date. As Dr. Bendikson was sharing, with increasing age, fertility rates go down. And so by freezing eggs from someone who is young, we can use those eggs for someone at any age in the future when their fertility may be decreased. So the whole process is we stimulate the ovaries, we remove the eggs from the body, and we freeze them for later use. People ask, when should I consider egg freezing? Really, whenever you are ready is a good time. You know, I would say there's no age that I say you must start thinking about it, because some people will start a little younger thinking about those questions, some maybe a little bit older. But important things that you need to ask yourself: how old are you? And so what might your fertility potential be today? How old will you be when you actually think that you want to have your first child? How old will you be when you want to have your last child? And also an important question is, how many children is in your ideal family? If you say that you want one child, when you conceive, that's one child you may be completed. However, I sometimes feel like children are like potato chips. It's hard to, if you have a good one, you don't want to stop at just one. And so then you might want to think, well, if I have more children, if you're pregnant for 40 weeks. So let's just round that up to a year. You might wait a little time before you want to have your second child, or third or fourth. And so that might be even another year. So you've gotten a couple of years older. My lights just went out. I'm not moving in my room, but so as you've waited in between children, your ovaries are continuing to age. And so if you do egg freezing, even if you don't need to use those frozen eggs for your first child, you may need to use those frozen eggs for a second child or something later on down the road, or maybe your third or your fourth, and it keeps those options open for you. So let's talk a little bit about how the egg freezing process works. Every month, your body recruits a cohort of eggs. It's just a group of eggs from your ovaries. They start growing and maturing. In that cohort, you have one that your body selects and says, this is my dominant, this is my best egg, this is the one that's going to ovulate this month. And then those others that are lost every month are providing hormone support for that one. And so we are trying to capture the eggs that are ovulating and are maturing in that particular month. So we're kind of opportunistic. We're trying to get that one egg, but at the same time, your body has kind of breaks. And so with the breaks that are set with your body knows, it says, hey, I'm only going to ovulate one. I'm not trying to have a litter of puppies. So it doesn't send more and more hormone out. Well, we are going to try to capture and bypass your body's brake system. We do injections. Well, actually, you will do injections of fertility medications that's the exact same hormone that your body is producing. Your body produces a hormone called FSH, which is follicle stimulating hormone. It stimulates follicles to grow. In those follicles, those are those fluid-filled sacs that Dr. Bendikson talked about, where eggs are. As those follicles are growing, those eggs are maturing. And because we are taking off the brakes, we are allowing some of those follicles that might have been providing support for the one dominant egg we're allowing those to actually get that hormone support so they can also be dominant and mature follicles. So during the course of your stimulation, for about 10 days, sometimes as long as 2 weeks, people will be injecting hormones to get that batch of eggs to mature. Sometimes people are like a little scared. They're like, oh my gosh, you mean I have to give myself shots? It's a scary thing to think about at first, but it's actually surprisingly easy after the first time. We at Kindbody will spend a lot of time, like we have videos and we will do some one-on-one learning and teaching to tell you how to mix your medications, how to give your medications. But the needles are not like a big needle. It's not like getting a flu shot in the arm. They're very small, tiny little needles that go just underneath the skin. And most people are actually, after their first shot, they're like, oh, I was scared for nothing. This was a lot easier than I thought. And then afterwards, after 10 days of doing this, I'm like, now, aren't you really proud of yourself? You did something you'd never thought that you would be able to do. During that course of injections and medications, because we have taken the brakes off, we want to watch your ovaries very closely. Our goal is to get as many healthy eggs as we can, but we want to do it in a safe way. So over that 10 days of injections, maybe 2 weeks, we are doing very frequent monitoring with internal ultrasound, so we can watch your ovaries and we can see how many follicles are growing, how fast they're growing, and what size they are. We are also doing blood draws at that time so that we're looking at your hormone levels, because that also sort of colors in the picture. If I have just a blood test or I have just an ultrasound, I get a black and white view of how your ovaries and follicles are growing. But if I have the two combined, it's more like a color picture. The final injection, when people are like, oh, I'm almost done, is an injection. We call it a trigger shot, because what this is triggering is it's triggering those mature eggs to actually go through their final step of maturation and then to be released and ovulate. But we don't want you to actually release the eggs. The eggs are too small for us to see. We can't find them if these tiny little microscopic cells are floating around in your body. So that's when we plan to do our egg retrieval. We do the egg retrieval about an hour before your eggs would actually be released. And we know when that time frame is, just because we know that you will ovulate about 36 hours after the retrieval. So we do the after the shot, we do the egg retrieval 35 hours after that trigger shot. The egg retrieval is a very simple procedure. You will take the day off work just because you will have some sedation. This is not anesthesia where you're completely asleep and paralyzed. You are breathing on your own. You're able to move, but you won't know that you want to move because you're going to be sleeping and having a really fantastic dream. I tell people that I think this time of year, I keep telling people Bora Bora sounds really nice, but so for about 10 to 15 minutes, you'll take a nice nap, and we will do an internal ultrasound. There is a needle that's attached, and it passes through the vagina into the ovaries, into all of those follicles, and we remove the fluid from the follicles and we pass it to our embryologist. The embryologist will then sort through all of that fluid, and they will tell us right then and there how many eggs we have. This is where things can be a little different. If we're planning to egg freeze, those eggs are mature eggs are frozen on the day of the egg retrieval, and a person knows that day exactly how many eggs they have available. And there are certain calculators that you can use and say, based on this many eggs, if I use them, what are my chances of having a baby? Now, their other option is doing embryo freezing. Embryo freezing is the exact same process as egg freezing. A woman going through the egg freezing process will experience nothing different if she's doing egg freezing or embryo freezing. The only difference with embryo freezing is, rather than freezing the eggs are fertilized with sperm, and then the fertilized eggs become embryos, which are grown into the lab for several days before they are frozen. And so for couples who are absolutely certain that they are going to conceive together, embryo freezing is an option. For women who are single, egg freezing may be a viable option, because then you keep your options open for your sperm source in the future. So what comes next? We store the frozen eggs or the frozen embryos, and they can be stored in the facility for really as long as you want. I find it fascinating. Just a few years ago, the embryo that was frozen the longest, that has resulted in a live birth, was frozen for over 26 years. The woman who gave birth to that embryo was 24, so she was younger than the embryo. Our freezing and thawing technique has really come a long way in those last 25 years. So we don't think there's a real time limit for how long embryos or eggs can remain in storage. And when they are thawed, we expect them to be as viable on the day of thaw if they were stored for 1 minute or if they were stored for 15 or 20 years. when we're talking about fertility preservation options, our really hope is that we want you to get pregnant naturally. Nobody dreams of going through fertility treatment and having a doctor do all of this and medicalizing what really should be a very personal and intimate experience. But if you do get pregnant on your own, fantastic, congratulations. We'll be super happy, jumping up and down and celebrating with you. But if you want to get pregnant at a later date and at some point you find it's more difficult later on, you have those eggs or possibly embryos for you to use at a later time. So let's talk about where egg freezing and embryo freezing changes and becomes IVF. The process leading up to getting the eggs and getting the embryos is exactly the same. We fertilize the eggs, but then we have these embryos. Embryos are what ultimately will grow into become a baby. And those, if it's eggs, we can thaw them, we fertilize them, and then we grow them to the embryo stage. And then those embryos are transferred into the uterus. And it's kind of a specific timing because we want the right hormone environment for the uterus. We want the uterine lining to have the right thickness and the right architecture to accept and really welcome that embryo. If we have frozen embryos, rather than thawing eggs and fertilizing them, we just thaw the embryos at the time of the appropriate transfer. And the transfer is really, it's a pretty straightforward type of procedure. You are awake for the procedure. We just place a speculum, we can visualize your cervix, and we have a small guide with the embryo that passes through the cervix into the uterus to transfer the embryo exactly where it needs to be in the uterine cavity. So then the next question is, what does third-party pregnancy, third-party fertility treatment mean? At Kindbody, we call it family building. Any individual who is single and wants to be a single parent by choice, or couples that are in same-sex relationships where they don't have an egg and a sperm, will have to consider third-party reproductive options. This is using donor gametes, that's egg donors and sperm donors, or a gestational carrier. And so because you have to have eggs, sperm, and a uterus to create a pregnancy, if you're a couple where you have two men who have sperm only, they will need to use an egg donor and a gestational carrier. If you have two women who don't have a sperm source, they will need to find a sperm source, which is donor sperm. So that's kind of what we call the third party. And it is family building because it does take, in this case, it takes 3 to create that village, or sometimes more than 3 to create the village, instead of just a couple that's in a straight relationship in a monogamous situation where it's kind of a little bit more standard and traditional. And so this is just our third-party family building options, and we do have availability at Kindbody for egg donors, sperm donors, as well as gestational carrier programs. So this really tells us paths to parenthood. As we've talked about, the journey can be straightforward. It can be curvy. You can try different options. Some people will conceive naturally. Treatment options including intrauterine insemination using donor sperm if necessary, in vitro fertilization using donor egg, donor sperm. Ovulation induction is the stimulating the ovaries portion for ovulation, and sometimes that can be done simply with oral medications alone if we're doing IUIs or timed intercourse. And then our family building options is egg donors, sperm donors, and gestational carriers. So next steps, if you're trying to get pregnant today, tomorrow, someday, I think it doesn't hurt to just start learning about your body and learning about your fertility and learning about the options that are out there and where things stand for you. So I actually am really privileged. I get the opportunity to introduce you to Roberto. I've been so blessed at Kindbody to have had interactions with Roberto, and every time we interact, he's on the East Coast, I'm on the West Coast, and it's always by Zoom, but he always makes me laugh, and he always says something that's super inspiring to me. But he has his own story, and so it's my pleasure to introduce you to Roberto Fontanez so that he can share his story with you.
Oh, thank you, Dr. Annie. That was really sweet. Hi, everyone. My name is Roberto Fontanez, and I'm a clinical laboratory scientist with Kindbody. Thank you for the genie shirt. Yeah, we like to make the magic happen here. And I would like to start with kind of that roller coaster idea. You know, that roller coaster idea, you may not have known that you were going to be there, but you show up and you trust us, and we're going to guide you along the way with good healthcare, good science, and good hope. But I also wanted to tell you about my pride. My story through pride is that, you know, some people have been dreaming of that roller coaster their whole life. I'm an adopted child. My father is a single man who saw a troubled youth and knew he could change their life. And he experienced his own journey with the difficulty of trying to be a father. And some people, men dream of being a father too. And he was my original kind dad. When I originally got into science, I was into the cool stuff like cancer research and lasers and all this stuff. And when I kept thinking about how I got to where I was, I kept thinking about family. And I was drawn to Kindbody because Kindbody's mission is to make those dreams of wanting to be a father or being a mother or having a family possible for anyone without barriers. I'm going to shout out to someone in our chat said, is this not natural for LGBTQ families? It's difficult. It is surely difficult with surrogacy laws and friendships being made and relationships challenged. It is difficult, but I think it is natural that everyone wants to share the love that they have and that they've experienced with another person. I spent a large portion of my life in the military. And in the military, I've seen what families are willing to sacrifice for what they believe in. And to think there was a lot of love put into creating my brother and sister in arm, and here they are in harm's way. I can't imagine what these moms and dads are thinking of. And then I think about those people who started their own families while they're in the military. We have fertility services that service our service members that in the most challenging times and most challenging places, you can still be a mom, you can still be a dad. And I want to bring that message to everyone in that there will be hurdles. There may be long nights and swelling in places that you don't want it to be and hard questions that you don't know how to ask. And that Kindbody has brought on board the most amazing people with the most amazing hearts to try to make that path easy for you and to try to make it better. We speak to our fathers with all the love that they need and they deserve. It's scary to be found out that over a third of men may experience fertility issues. And queer fathers don't know whether or not they can go through one state or another for surrogacy. Where are the trusted surrogates? There are concerns, and our teams will guide you through it. And for our transgender patients that wants to still be moms and dads but want to preserve before they go in, we'll guide you through that too. And my earliest research in cancer research, I've also made a special focus on oncology patients. Patients are experiencing cancer at higher rates and younger. And sometimes planning early is the best way of still being able to survive that and fight that while still having hope for the future. My goal at Kindbody is to be the voice and to make a space and to give hope to any patient that will trust us enough to know that we're going to help you get your dream. So that's me. And it's really, really an honor to work with all of you and to see our patients and our future friends. Thank you, Hillary. Let's get you all to be parents first and our friends along the way. So thank you all for trusting us and for taking the time to meet with us and learn about how we can help everyone.
Thank you. Thank you, Roberto. I'm going to do a quick, very big thank you to you first, because without you, I know also without Dr. Henne and without Dr. Bendikson, this wouldn't be possible, but thank you you're not always the face of what we do at Kindbody, but without you, this wouldn't be possible. So it is just a testament to that. Like, we are a team and everyone plays a role. And so thank you so much. And we're so happy that you could join us, and we could celebrate you today. So we're going to take some questions in a second, but I have a few little housekeeping things. So thank you everyone for joining us. Kindbody does accept insurance. I saw a few questions come through. If you have any questions about whether or not we take your insurance, how much coverage is, please just email navigator@kindbody.com. Another part of our team is there to answer all of your questions, and they can help you figure out what the best plan is for you, what coverage you have. If your employer offers a coverage, if your employer doesn't offer coverage, tell them to look into Kindbody, be the advocate in your company for that fertility benefit. But for everyone joining us tonight, we do have a special cost price for you guys. So June 101 is the code. It's going to give you 50% off assessments if your insurance doesn't already cover that. So schedule it. The more you know, knowledge is power. And then gives you a discount off of egg freezing, an IVF cycle, and off of IUI. So please, June 101, we'll also send a follow-up email so you'll get all of this. But please book an appointment, kindbody.com/book-appointment. If you're in Los Altos, go see Dr. Henne. If you're in the LA area, go see Dr. Bendikson. You already have a relationship with them, and see how wonderful they are and knowledgeable they are. So please, and someone just asked, does the code apply to an appointment in July? Yes, just make the appointment now. And also, if you book an appointment for an assessment, when you go to, should you move forward with egg freezing or IVF, the code will still apply. So those discounts can move forward with you as you go through your journey. So let's take some questions. I took some notes here, but let's get some more. Dr. Henne,
shout out to Dr. Garvin in Atlanta, just opened.
What was that?
A huge shout out to Dr. Garvin in Atlanta. We just opened a place and we're ready to go.
Yeah, if you're in Atlanta, we do have a clinic there. I can run through our locations. We have 2 in New York City, 1 in Princeton, 2 in the Bay Area, 1 in Vidye, 1 in Los Altos, 2 in the LA area, Santa Monica and Century City. We just opened up in Atlanta. It feels like a year ago, but it was maybe 3 or 4 weeks ago. And we'll be in Austin in 2 weeks, Denver and Minneapolis coming this year. And 2022 I'm going to get a lot of frequent flyer miles. I feel like we're going to be busy.
Hawaii, here we come.
Yeah, exactly. I saw a question about how does your hormone levels impact you being pregnant? So should you get on like a hormone drug before or after if you have hyper or hypothyroidism, and how that impacts you as you go through fertility treatments and or pregnancy? Dr. Bendikson, you want to take that one? I think you're on mute. Asked on mute. Dr. Henne, while she figures that out, I'll get.
Oh wait, I got it. Sorry.
Got it. Yay. There we go.
Sorry, I was trying to talk, but it wasn't letting me unmute. No, so thyroidism, certainly. I mean, there are so many hormones that play a role and influence the reproductive system. And it's amazing that our bodies work so well all the time, because it is such a delicate system and they do interplay with each other. And so when you have thyroid issues, both high or low, it can absolutely influence your regular menstrual cycles. And so that can influence when you ovulate. There's been some correlation with low thyroid and miscarriage. And so it is something that we actually very carefully watch, and we check thyroid levels on any patient that is interested in getting pregnant. So that's, yes, 100%. That's something that needs to be addressed before you get pregnant.
Great. Dr. Henne, we kind of touched on this a little bit, but is there an ideal age or an age, a cap for when someone should go through egg freezing? If you reach a certain age, would you recommend that someone not go through it? And same for IVF.
So for egg freezing, I don't want to say the younger the better, because obviously I don't need a 10-year-old thinking about egg freezing. But peak fertility for women is really at age 27. So at age 27, we start getting a slow decline in ovarian reserve and ovarian function. So I would tell people, if you're thinking about egg freezing and you have the opportunity to do this in your late 20s and early 30s, this will give us our most optimal yield of eggs. And the more eggs we have, the better chance that we have for actually having those eggs create a baby in the future. And while no, there's not technically a quote cap, the challenge that we have as women age, we're going to get fewer and fewer eggs in any given cycle. And so above age 38, 39, the likelihood of having enough eggs to freeze to actually result in a successful live birth down the road is low. And so the challenge then becomes weighing costs and benefits and risks of going through that procedure when the yield may be low. So my recommendation would be late 20s, early 30s. And if you are approaching late 30s and 40s, you may want to be considering just health and pregnancy and when you're planning to use eggs and maybe even conceiving. Now for IVF, it's a little bit trickier because we have sperm. We're not thinking about long-term down storage in the future. We're thinking about being pregnant right now. We would recommend, again, I would say your best chances of pregnancy are going to be the younger a woman is when she's going through the IVF procedure. And there are calculators and predictors that you can find online that will give unique information for people and their specific situation about how likely it is to conceive. But I would generally, there are very, 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 maybe I should have a few more, very few live births that have ever been reported from doing IVF for a woman who is over age 44. In these cases, we would really be talking about some of that third-party family building and using donor eggs and using eggs from a younger woman to conceive and carry that pregnancy.
Thank you. Dr. Henderson, how should someone approach fertility preservation if they have PCOS? And this wasn't asked, but let's also throw in endometriosis and/or fibroids. So the whole gamut of complications when it comes to fertility preservation for women.
Was that for me or for Dr. Bendikson?
I think
Dr. Bendikson.
Dr. Bendikson, I said that.
I'm happy to take it, Melinda.
Thank you.
I can too.
And so I think obviously depends on if you're talking about egg freezing or just getting pregnant. The process of egg freezing is possible in both of those situations. Women who have polycystic ovarian syndrome, they don't ovulate regularly, but that's not a problem for starting an egg freezing cycle. We can absolutely work around it. I think the biggest issue with women, especially younger women with polycystic ovarian syndrome, is that they tend to make a lot of eggs. And so sometimes the symptoms can be worse in the cycle, but we know that ahead of time. And so we take measures as healthcare providers to make sure that we minimize those side effects. So that's really important to know. And in terms of women who have PCOS, when they're trying to get pregnant, a lot of that what we do will depend on how regularly they're ovulating. Some women who have PCOS, they do ovulate some of the time and they can get pregnant on their own, and other women don't ovulate at all. And so we need to get involved because we need to give some very simple oral medications just to get that woman to ovulate. So that when they do that on their own, we don't have to get involved in any other way. We don't have to do an IUI in that situation because the only thing that's missing is that they're just not releasing that egg every month. When it comes to endometriosis, that's a little bit more challenging because endometriosis, which is a disease that is super common, we think that maybe 1 in 10 women have it. A lot of women who have endometriosis have symptoms, but a lot of them don't. And endometriosis can increase your chance of having infertility. Endometriosis can sometimes decrease the quality of the eggs. It can also sometimes decrease the number of eggs that you have. So for patients that know that they have endometriosis, I actually think if they're thinking about fertility preservation, it's even more imperative to do it early and more imperative to actually think about it because of that potential of having a harder time getting pregnant. And again, this is exactly kind of what Dr. Henne said. We don't wish for you to ever use those frozen eggs that you worked so hard to freeze them, but I actually don't want you to have to use them. But if you are going to use them, let's think about using them maybe for a second pregnancy. So if you have endometriosis, now you might have age as an issue that's causing it to be harder to get pregnant. And then on top of that, you have endometriosis. So maybe that first pregnancy is going to be easy, but then that second baby or the third baby when you're now 38, 40 is going to be hard because of those two compounding issues. And so if you have those eggs frozen or embryos frozen from when you are younger, then your chances of getting pregnant when you're older are that back of your younger self. So it's just important to keep in mind when you're thinking about your family building plans.
Yeah, I think it's so fascinating, the question, not when do you want to have your first child, but also when do you want to have your last child? And it really puts this into play. So that's helpful. And I have one more question, Dr. Henne, I'll give it to you. How many, and I know this differs by age and everything, you can go into more details, but how many frozen eggs would someone look to have per live birth?
So that is $1 million question. And some of it will depend on age at the time of the eggs are retrieved and frozen, as well as the numbers, because as Dr. Bendikson mentioned earlier, we do see a decline in both quality and quantity of eggs as women age. In general, when I talk to my patients, I tell them to have a really reasonable, good chance of having at least one live birth. I would like to see 10 to 20 eggs. And that seems like a really large number, but I do remind people not every egg will actually fertilize, make an embryo, and make a baby. And so there is a little bit of a drop-off rate. So I feel very comfortable if I have between 10 and 20 eggs that will be able to help somebody to have that family later on.
Wonderful. Thank you. And Roberta, since we have you,
Hi.
and we never have a wonderful male guest speaker, can you tell us specifically what you're looking for in a semen analysis? I think most of our guests tonight are women, but so what they're looking for, what they could be analyzing when their partner comes home with their results, or what they might be looking at when they are looking at a sperm donor.
Well, I would say first, I keep a little bit of sperm on my vest at any given time for moments just like this. And a good semen analysis is a really important question because first, I would like to say that when we give this care, well, gender may occasionally determine what tissue we're harvesting from you, but information is what builds the family. And I firmly believe that as we provide the best care for our fathers and our sperm sources, and that we help both parties out. And a good semen analysis, it's not high score. It only takes one. So it does, not being sterile is the best thing. We have reference ranges that were defined by the World Health Organization as, above 40,000 or 40 million sperm. But remember, we're counting in the millions. So when you're looking at a semen analysis report, the heart can stop for just a second when you think of something that's abnormal. But to harken back to earlier when Dr. Henne was explaining what an intrauterine insemination is, an IUI doesn't just put the sperm in the right spot, it also concentrates it for you. So rather than, a shotgun shot into a big open room, we're giving the providers sniper rifles, and you can get exactly where you need to be with the best quality sample. Even if like an IUI takes a normal sperm sample that can have lower than average motility, and it removes all the non-smotal sperms so that only the best swimmers are still there. So having a high concentration is helpful, but it's not the ultimate determining factor. And even low morphologies can change on the sperm source's health, whether or not they're smoking. Are they doing Soul Cycle every single day? Maybe not do that. So these factors can change. The most important thing is that you remain optimistic and that you know that you're not sterile. And even if you're not sterile, the path to fatherhood doesn't have to be you're the sperm source.
Awesome. Thank you. We're going to end it there tonight. Everyone, thank you so much for joining us. Thank you to Dr. Henne. Thank you to Dr. Bendikson. Roberto, thank you. It's our pleasure to have you here.
I'm so glad to be here.
Again, we're so lucky to have everyone here on our team. If you have more questions, please reach out to us, navigator@kindbody.com. Please follow us on Instagram. We're always sharing like really fun facts and stats. So it's just Kindbody. And please, if you are more interested in, if you're interested in learning more about the LGBTQ family building opportunities, please join us on June 24th. At 8 p.m. Eastern, 5 p.m. Pacific time. We're hosting another event that will have a much more like niched focus on the LGBTQ community. Sorry, it's been quite a day for me. And we hope that you'll join us and we'll go into depth there. And we do hope that you'll schedule an appointment. Knowledge is power. So come in, see what's going on, and let's help you build a family. Awesome. Thank you, guys.